I think we might be ready to start. So if that's the case, let me extend a very warm welcome to everyone here, alumni, family, friends, to the University of Melbourne. Hopefully it's been a really good chance for you to get back and to reconnect and to feel nostalgic about old haunts. Great to see so many people here from this group, and it's a very elite group, I should say. It's not quite as many as we anticipated, but probably high quality on average. This is a PsychTalks event, and I'll say a little bit more about that later, taking place as part of Reunion Weekend, and it's being organised by the Melbourne School of Psychological Sciences, which is part of the Faculty of Medicine and Dentistry and Health Sciences. It might not have been while some of you were doing your medical training. I think psychology was in arts before about 1992, but we're now part of your faculty. And I'm especially pleased to welcome our event partners, the Mental Health Foundation of Australia, and they will have a few words to say at the end of this event. First, let me acknowledge that this meeting is taking place on the lands of the Wurundjeri people of the Kulin Nations, who are the traditional custodians of the lands, and let me pay my respects to their elders, past, present and emerging, and also extend respect to any Aboriginal or Torres Strait Islander people who are with us today. And a couple of quick housekeeping announcements before we get started. Could you please make sure to turn your mobiles onto silent, and also this event, as you can see, is being recorded, so any embarrassing things you do or say will be recorded for posterity. Please be aware of that. We are going to have some time at the end for audience questions, so if you have things you would like to ask our wonderful panel as things come up, please leave those questions towards the end. There'll be ample opportunity for you to have them heard. And if you are tweeting, you can use the hashtag PsychTalks. And just to give you the brief background on PsychTalks, you can see in the background, it's an initiative that we've been running for a couple of years now, a forum for discussions, ideas, and this one we thought it would be a great idea to talk about mental health among health practitioners, because it's a very timely issue. It's very much in the news, and it's very much of personal concern, I'm sure, to many of those present. So before I speak to our experts here, just a few basic factual statements to try to orient our discussion. So there was a big review published in 2017 looking at mental health and well-being of doctors in the UK, and I'll get to the Australian evidence soon, which found that a startling 31% of doctors experienced what was psychiatric morbidity. Rates vary for different studies, but the average across 30 studies was 31%. One third of doctors experiencing levels of diagnosable mental disorder, especially high among GPs and consultants, and also similar proportions experiencing what's called burnout. And burnout is often defined, at least within psychology, as some combination of cynicism and lack of empathy towards patients, a feeling of a loss of personal efficacy in practice, and also emotional exhaustion. So similar proportions of medical practitioners were feeling those things. Rates of burnout were related to job stress. It should be no surprise that people feel burned out from the work they're doing, and levels of job stress relate very transparently to that, and appeared also to be increasing over time. And part of what we're going to talk about today is the reasons behind some of those historical trends. Closer to home, there was a Beyond Blue funded survey a few years ago done on doctors and medical students, which have found substantially higher rates of distress among doctors and suicidal thoughts as well, I should say, as among the general population, and also higher rates than in other professions. So there seems to be something particularly challenging about the medical workforce space. Again, some incredible statistics, some alarming statistics. 10% of doctors reported having had thoughts of suicide in the previous 12 months. Higher rates in the general population, and again, higher rates than in the other professions. If you looked at your Medical Journal of Australia today, there's a new article by Dr. Anne McCormack, who's an endocrinologist at St Vincent's Hospital in Sydney, reflecting on having lost 3 colleagues in recent months to suicide, and noting that there's very strong epidemiological evidence that rates are substantially higher among doctors, especially female doctors, in recent times. And it does seem that this goes with gender and age to some extent. So you do find evidence from studies that younger doctors are especially vulnerable to poor mental health, report high levels of burnout, high levels of work stress. And you also find similar things for female doctors on average: more distress, more anxiety, more depression, more suicidal thinking, and especially more conflicts over managing personal and family responsibilities on one hand, along with career responsibilities. And as a final figure before I hand over to our experts, another interesting and alarming statistic: about 40% of doctors surveyed felt that medical professionals with a history of mental disorder would be perceived as being less competent than their peers. So as we digest those sobering numbers, let me introduce our distinguished panel from left to right, or right to left, from your standpoint, I guess. Empathy. So Professor Lisa Phillips is a clinical psychologist who's Professor of Psychology in the Melbourne School of Psychological Sciences and also its Associate Head of School. She's done very important pioneering work on identifying young people at especially high risk of developing psychosis and developing treatments and preventive interventions to stop that happening. And more recently, she's broadened her work out to look at the determinants and remedies of mental ill health among undergraduates at the university. And again, those of you who've been away for a while might not realise the size of our student body now. It's, in enrolment terms, about 69,000. It's an astonishing number of people enrolled at this university, an astonishing amount of distress out there, and Lisa's going to figure it all out and solve it single-handedly.
3:30.
Ben, next is Professor Sidney Block, one of Australia's, I think, really great medical humanists. I'm not sure if he likes that title, but I'll use it anyway. He's Emeritus Professor in the Department of Psychiatry and the Centre for Health and Society here at the university. He's trained generations of psychiatrists at St Vincent's Hospital. He edited the Australian and New Zealand Journal of Psychiatry for more years than he would like to remember, I'm sure. And he's written very extensively and I think cogently on medical ethics, psychotherapy, psycho-oncology, no fewer than 14 glorious books. And I think he has a few with him in his backpack.
Well,
and last but not least, to my left, Dr. Jill Tomlinson. Jill graduated from this university some time ago with the rare distinction of achieving first-class honours in both medicine and surgery. After completing her medical training, she undertook advanced training in surgical specialties, plastic and reconstructive surgery being where she ended up. And somehow she manages to combine a very busy surgical practice with being especially editor for social media in the Australian and New Zealand Journal of Surgery. She contributes to training junior surgeons. She's held numerous senior roles in an assortment of medical societies and has been a powerful voice, especially recently for gender equity in Australian medicine. And you might have come across a letter she co-wrote to the MJA not so long ago. So Jill, let me start with you. So when you hear some of the statistics that I just mentioned about the scope of these problems, do they ring true to your experience?
I think there are a number of reasons why it might be increasing in frequency and in severity. One of the many things for junior doctors at the moment is the tsunami of medical students that's coming through, that's been referred to for a number of years, and that leads to junior doctors not having the certainty that used to exist that once you become a medical student and you work through and become a junior doctor, that you will have a reasonable opportunity of ending up in the field that you wish to end up in. And certainly the demands that are placed from a very early stage to do research, to get your CV looking perfect so that you can hopefully try and get a position where you would like to be, is creating extreme stress. There's also, I think, a much busier time for junior doctors these days. While junior doctors have always been busy, the workload has always been high, and There is probably better safe hours these times than in decades gone by, but the intensity of the work and the relentless nature of it is certainly something that, from a junior doctor point of view, we see. But the thing is, even once you stop being a junior doctor and you successfully make it through as a general practitioner, as a specialist in surgery or any other field, the demands don't stop. For women in particular, where there is higher rates of mental illness, while some people might think that that's, and here I'm sort of tongue-in-cheek because women are more vulnerable and things like that, and I've spoken out against some recent statements about that, that women are often more likely to be part of a sandwich generation, sandwich between child-raising responsibilities and caring for older parents. And traditionally in our society, that those sorts of roles have been seen as women's work. And so it's really something where the juggle is strong, and the demands of the profession are also very high.
So I think it's really good that you talk about some of those systemic sort of level problems with the nature of the work and the nature of the workforce, and as you say, the tsunami of graduates, and it's not just about people being individually vulnerable or individually perfectionistic or some other thing that's sometimes referred to, although that I assume is part of the issue. I mean, are there any sort of systemic solutions that you can see? I think you've spoken about potentially opening up part-time training or things like that. Is that something you could do?
Yeah, certainly for people who are in a very strong juggle, the lack of availability of flexible and of part-time work often means that people are forced to either choose between working and being terribly overloaded and not working. And for many years now, I've been trying to encourage, both from a flexible training point of view, which has various models, but part-time is one of them, and also we need to look at flexible working arrangements. So it doesn't have to be that you're either working 65 hours a week or 0 hours a week. There's opportunities for people to be in the medical workforce but not working full-time. In terms of solutions, one of the other concerns that people have raised across Australia that's a barrier to health practitioners seeking care is the mandatory reporting requirements around health practitioners. And while West Australia has an exemption for health practitioners or medical practitioners, so that if you go and see a psychiatrist, general practitioner, anybody about your mental health concerns, you don't have that degree of concern that they're going to report you to AHPRA and that your medical registration will be at risk. It is nevertheless the fact that in other states, health practitioners often have that concern. And it's sometimes because they misconstrue what mandatory reporting means. If a doctor goes and sees their general practitioner and has mild depression or moderate depression, they're not going to be reported to AHPRA in a mandatory fashion unless they're actually posing a risk to patient care. But that concern that you'll be reported to AHPRA and have your medical registration is something that is a significant barrier, and it's why the Australian Medical Association and other organisations have been lobbying at a COAG level to try and get changes to national law to reduce that barrier.
So in terms of flexible training, how much progress is being made?
I particularly look at the surgical side of things, which was fairly slow initially to get on board. I think when I was initially looking at statistics in 2009, so 10 years ago, only 0.3% of surgical trainees were able to access part-time or flexible training. While haven't seen any statistics recently, it does seem that essentially from an accreditation point of view, you're no longer going to get your surgical position in a hospital accredited unless they have the option for you that there may be. I mean, they just have to say yes. Whether they actually end up approving it is another thing to be seen. But it is something where it's becoming part of an accepted requirement that you should be able to ask for it and that you should be able to be given it if you request it. So there's still a lot of work to be done, but certainly the College of Surgeons and other specialist societies and colleges have been working very hard on that.
So there's obviously some policy solutions. Another sort of more macro level thing that you've, I think, been passionate about, which I wanted to explore, was changes in the nature of healthcare work and medical work, maybe in particular, to do with just the quantity of data that people now have to deal with and manage. Do you think that's a significant contributor to some of the stress that people feel in this line of work? And if so, what does one do about it?
So I think it's something that both affects healthcare practitioners and also the broader community. I suspect that many in the audience, like me, will occasionally lament the fact that people can get your email address and you can be sent emails from everywhere, and the number of streams of different communication channels coming in is very high. As we see digital health transforming the medical workforce and medical workplace, that also leads to significant changes and challenges. In the United States, there's been a lot of concern that electronic medical records are contributing to burnout by placing huge data demands on practitioners. I think there's less evidence that that's the case in Australia. I think Australia is certainly different to the US in terms of both how the electronic medical records work and also their penetration to date. But the challenges of digital health and the challenges at the moment that we actually can't process all of the data information that we're collecting, that our knowledge of clinical informatics within the healthcare profession is actually very low. And it is a challenge for the next 5 or 10 years to build the digital health workforce and try and have the tech supporting doctors so that doctors and other health practitioners, so that it actually helps doctors work rather than creating work.
So I was stalking you online this morning and your Twitter feed, and you pointed out proudly that you're wearing the Doctors for Doctors pin. So who or what are Doctors for Doctors?
So Doctors for Doctors is set up through both the, we'll say, AHPRA, or the Medical Board, and the Australian Medical Association. It is aiming to allow medical students and doctors to be able to have avenues for seeking healthcare, particularly around their concerns about mental health. Because we wish to reduce the barriers, we wish to make it a safe place where people, if they have concerns, are aware how to access help and are able to access that help without the stigma that really surrounds things. Because I think, as you said, 40% of people in a survey would say that they would feel that a doctor who had a mental health problem was less competent, efficient, and so on. And I think that is certainly something that unfortunately means that so many medical practitioners will have had the experience where they get up one morning and they hear that their colleague's no longer coming to work. And we need to stop that.
So I think one thing that is very clear in your own work is also through your involvement in a lot of medical associations and societies is the importance of a sense of community, which I guess you would derive through the Doctors for Doctors group. But can you say something about the role of a sense of belonging, the role of a personal network, and how much different specialty societies can cultivate those things, and whether, again, without showing any surgical chauvinism, whether this differs between different fields of practice in your area? Are some areas within the broader health field sort of leaders in cultivating caring relationships and caring networks and caring communities?
And I think those caring communities and caring networks are absolutely vitally important in keeping people engaged and allowing people to discuss concerns and address them. There are certainly differences that I see. I recently had the pleasure of joining the Austin and Northern Training Hub surgical dinner, and they had about 100 people there with trainees and surgeons having dinner, and it was a wonderful network where I really felt that everybody was pulling together and working as part of a community. And I contrasted that, in fact, with my plastic surgical training, where rather than having one or two hospital, Austin is I guess Austin and Northern, two different hospitals, but one training hub where everybody knows each other and has a community. In plastic surgical training, every 6 months you move around to a different hospital, and in some ways I used to liken it to being a permanent temp. Every 6 months you'd move to another hospital, you didn't know how to refer a patient for an x-ray, you didn't know where the car park was, or all of those sorts of things. And certainly I do think that I would have found it easier to be part of a bigger network than perhaps what I found in plastics, where every 6 months I was again moving and going to be the new kid on the block and not have that network throughout a training program.
So do you think that is dangerous?
I think probably that's partly why I got involved in various other organisations. So I was heavily involved in the Victorian Medical Women's Society and the Australian Federation of Medical Women across that time, and that actually was where I had my mentors and people that I could bounce things off, and that was both very useful for me and I guess perhaps was a little bit strange in a way that I would have mentors who were general practitioners, obstetricians, gynecologists, rather than saying, oh, well, yes, my mentors are actually plastic surgeons. And it may well have shaped where, rather than perhaps ending up as somebody on a specialty society, that I'm more involved with those organisations and the Australian Medical Association, because I guess it's given me a broader than plastics experience. So I think the great danger is if people are moving around and they actually haven't been able to find a network for themselves, a support network, because certainly without that support network, I don't know that I would have made it through my training.
So I'll turn to you, Sid.
Yeah.
So is there a warm embrace of a psychiatric community as well? Can you imagine 100 psychiatrists at dinner?
Well, I have participated in quite a number and survived. Many of the things that Jill says I could obviously want to echo, but also we want to go over other things. But the idea of a community of people who are engaged with the same principles, the same goals, which are noble. I mean, a lot of people scoff and say, oh, talk about the nobility of medical healthcare. What nonsense. So in psychiatry, for example, we train as cohorts, by which I mean that 50 or 55 people come in. They train here at Melbourne University, so they see each other, they get to know each other from day one. And then, year 2, year 3, they're passing through similar sorts of experiences. They're also going back to their hospitals for the rest of the week, and then, of course, there's an exchange that way. There's another sort of community which I think every single health practitioner, I'll just say doctor to make it easy, which every single doctor should avail themselves of, and that is what we call a peer review group. Other people call it other things. So in psychiatry, almost axiomatically, people are going to become a member of a peer review group. It's sort of odd how it crystallizes actually, but people find each other, as it were, and then 6, 7, 8 people. My son, who's finishing physician training, has been part of a peer review group. The ones he studied with, so to speak, and even the ones he was at medical school with, and they used to meet together. Anyway, without the details, I have known from personal experience and talking to lots of people that if you belong to a group of 6, 7, 8 people, for years on end, you will feel supported. There's no competitiveness in it. And I honestly don't know if surgeons belong to peer review groups. They can meet once every 2 weeks, once a month. You can go to dinner. You don't have to go to dinner. It varies considerably. But that is the most important community. If I just extend that, the community of a hospital or a clinic or whatever is the other community that there I am very distressed, to be quite honest, because I think those bigger communities lack a huge amount of, I'm going to go use the word empathy, respect for others. It's, here I can go for a long time on the negatives, and I don't want to because we're here to try and find ways of moving forward. But our systemic, if you like, let's call it level of practice leaves a lot to be desired. And I think the lack of respect and the criticism and the negativism, I've seen it and I've heard about it from lots of people because I'm vitally interested in trying to bring it to an end. And so I better stop, but can I just add one comment? Later on, you've given me a question about, well, what should these, the big ones, the health educators, the directors and so on, what should they do? They should belong to a peer review group for life, and they should have, if you like, retreats where they go out and learn about empathy and what it's like to be in a position of vulnerability and all the rest of it. Because people who reach this sort of managerial level, I don't think they get anything like this. All they do is they go up the tree and then eventually they're doing timetables and all those rather banal things. And then they sort of forget that there's a human environment which they are meant to be leading. So I think it's enough. Otherwise I shall really...
I'm not sure what you're referring to about the questions I've given you. This is all completely spontaneous.
No, it comes later. You asked me about the role of educators and directors.
Yeah.
Sorry.
Well, indeed I did. And again, there's lots of good research out about this coming from psychology as well, about the importance of groups and being embedded in groups as a protective factor against developing health problems of all sorts, mental and otherwise. So before I go further, though, Sid, I mean, would you characterise the current state of ill-being among doctors as being a crisis, or not quite? Would you use that word?
I wouldn't use that word because these sort of things have been spoken about for a long time. It does appear to be more prominent, and I think, as Jill was saying, the numbers, there used to be 3,000 students at this university. There are now, 69,000. People get lost in the maelstrom. So I think that things haven't changed, but they have changed. It's a bit, it's a paradox in a way. And the other thing, when we use the words like distress or diagnosable mental ill health, these are such vague words. If they spoke about it the other day, years ago, they would have used other words. And the terminology to me is quite frightening. Because at the moment you think that, every other person, like 2 out of 3, and this, 2 out of 4, let's say, are diagnosably ill with a mental illness. That's, absolutely absurd. The other thing is the DSM, the so-called Bible, came out 5th edition just the other day. 440 diagnoses. I didn't count them, but somebody has quoted that number. Years and years ago, the 2nd edition had about 40. 40 versus 440. So everything is diagnosable, and that's rot. And people, when they go through stressful encounters, or have stressful jobs, or having difficulties at home with children, that is not diagnosable mental illnesses. These are stressful situations. Once upon a time we used to call them situational reactions, not such a great word. So I think on balance we do not have an increase, we have a difference because it's being looked at differently, mental illness. And on the other hand, sorry, not the other hand, and the other is that it's being spoken about everywhere, whether it's in colleges, in the newspapers, universities. So, not crisis, I think it's sort of become a pseudo-epidemic.
So are we overhyping this?
Well, I don't think we necessarily overhyping. I think it's what we have to do about these things, whether they happened the other day or can happen tomorrow. I mean, looking at, let's say, my own son again, if he's going to have a career which is the equal of what he's been doing for 5 years as a trainee, I say, go and do something else, become a yachtsman, go around the world several times. Because, he's been going through a hell of a time, as are all his mates. And so, my only concern, what am I talking about? My concern is about tomorrow and the day after, and what we, as so-called experts, we're not, but what we can do, those of us who are worried about these things, can try to come up with ideas. We have to do that. because there are generations to come and we owe them this.
So again, just given your great maturity and the fact that you've been in your roles for some time, and how has health practice changed in a way that's relevant to the suffering of people in it? Because I mean, it's always been challenging, and people of all ages will talk about their training as being a time when they didn't sleep very much and there was lots of stress and lots of novelty. What has changed?
I'm not sure I get your question, to be quite honest. And I also think it varies according to whether you're a surgeon or a psychiatrist or whatever.
Any general truths at all?
You know, when you asked me to come on this podium, I thought, I don't know about the other bit, you know, I know about my own.
Talk about yours.
No, but I think in general, I truly believe in the idea of a person working with other people having various tasks, and they have to attend to all of them. Some are attending to the paperwork. I know that from my colleagues in the States, and it's dreadful. I mean, it's not medicine anymore. They even send their notes to India. Have you heard about this? Well, you can describe it later on, which I found astonishing. So I think if you are able to take up the roles that you play in a balanced way, and by which I mean you've got to have notes and you've got to, there's admin stuff, but if the patient is sort of getting lost in the maelstrom and somehow or another, oh, the one I saw yesterday, what was his name? Oh, was it Joseph? Or, you know, that's what I think is the difficulty for me in this respect. So I don't think there's anything new about, you know, practicing medicine. There's an ideal, and then there's all those factors that get in our way. And I don't think people who come to medical school and then into practice are essentially unfeeling people. I think it gets knocked out of them. You know, that's my big worry.
So you've written very extensively on the ethical dimensions of practice, clinical practice, and so poignantly about what you call the 3 E's, which I'll let you describe. You've already talked about empathy, which I think is one of them.
Yes.
But concretely, how would you embody those ideas of the 3 E's, which you're about to reveal to us, in a more humane kind of practice, and stop those things getting in the way of practicing effectively and humanely that are presently in the way?
Well, firstly, it's triangular, right? So each of these E's are equal value and equal importance. That's number one. And they represent facets of really the composite of practicing medicine in a fruitful way, in a productive way, in an enjoyable way, and that sort of thing. So before I forget, I better look up what I... Now, you've mentioned 2 of them, empathy, and you've mentioned ethical, and the third one is ethos. I'll start with the third one, just for the heck of it. You know, I've read my my ancient Greek philosophy to a degree, because I teach ethics and all the rest of it. But the idea of an ethos can be translated as a culture. And nowadays, culture is the word they use. You know, we got to do something about the bank culture, and about, as if there was a culture there that, you know, was rotten. We didn't ever talk to each other. Now we smile at each other in the morning. By ethos, I mean a group, a system, a community, lovely word that we used earlier, which has within it certain values that they prize way up. You know, the values of kindness, the values of generosity, the values of sensitivity, those sort of values. And I can't see why that shouldn't happen in a medical school or in a training program or in a department of surgery, maybe, I'm not sure. No, it should occur in all, you know, groups of that sort of kind. Empathy, I think, is so, if you like, self-evident. But you'll be surprised, as I was, came back from Oxford some years ago to this university, to an academic post, and I said, do you teach empathy, ethics? And the then dean, please, no names here, said, we don't need that sort of thing. It's common sense that you're, you know, sensitive and compassionate and that you act ethically. My goodness. Fortunately, a subsequent dean, when I went back with the same sort of issues about empathy and ethics, said, look, I think you've got some good ideas there, Sid. We really have maybe ignored this systematically. Write out a proposal. I did. Take it to the curriculum committee. I did. It's now a 2-year course in this university, of which I feel so happy about, because from the clinical year onwards, you're learning about what I regard as 2 of the 3 E's. So empathy is not simply, it's quite a demanding thing to do, but if I'm looking at this lovely lady in front of me and she's sleeping, which she's not, or she's overexcited, my empathy, my empathic attunement, my, if you like, trying to fit into her feeling shoes will enable me to make contact with you and able to say, you seem very excited about this, or you seem to be angry, or whatever it is. And empathy, in my view, in terms of psychiatry and all of, if you like, the human side of medicine, is the key. It's like a platform. And it's quite difficult to learn. So I have taught it for years through the humanities. I go to King Lear or Hamlet or Death of a Salesman or music, or it's a very enjoyable thing to teach, by the way. But students seem to be quite liking that approach, but it's not a common thing. Because for a lot of other people and teachers, they say, but exams don't involve King Lear, do they? And all that. Ethics, it's abundantly clear that if you don't act in an ethical way, then you might as well give up the whole of medicine. I don't simply mean sleeping with a patient. I mean a code of ethics. I've been very proud to be a member of our college, which has now produced its 5th edition of Code of Ethics. First one was 1992, and I've been lucky enough to be involved with all of them. And I'm not going to read this out now, but you can look this up on our college website. The 11 principles that make up this code are absolutely intrinsic to medicine, to good medical practice. So, without going into that, those are my 3 E's, and they all interdigitate, obviously.
And clearly there's a problem with empathy, because that's what burnout means you're lacking.
Yes.
So clearly there's something standing in the way of people having empathy, and I think lots of studies have shown that levels of empathy, at least self-reported empathy among people in training, tends to decline steeply, not because they're becoming different sorts of people, but because the demands of practice are somehow not allowing them to cultivate
empathy, Nick, also requires, if I'm trying to be empathic with somebody who's just lost their husband from a cancer or whatever, it's damn difficult emotionally. It's very tiring and so on. So, by the way, Nick here wrote a wonderful paper in 2007, Medical Journal of Australia, Humanising Medicine, the Role of Empathy.
It fixed everything. So Lisa, thanks for your patience. So I think, Lisa, you've been involved in training clinical psychologists for some time. Do you think the same sorts of issues arise in your field as do in surgery and psychiatry?
Definitely. I mean, a lot of what you've said, Sid, rings true in my experience, both in the training environment, but also in the working as a clinician environment. And many of the things that you've said that you feel should be embedded in training, I'm quite pleased to say that we here at Melbourne University, in our clinical psychology training, actually do already expose our students to. So, for example, thinking about self-care is something that we talk to our clinical psychology students in the first year of their training program, and talking about values and talking about your own motivation and what's actually brought you here, and trying to help people not to actually look a bit deeper beyond, I want to help people, but it might be that you're here training as a clinical psychologist because you like people listening to you, or you like telling people what to do, and actually having people think about that and not run away from it, but actually think about, well, how will that influence my practice? And if I'm someone who likes to have people listen to me, if I've got a client who doesn't listen to me, how am I going to respond to that person? And how is that going to then make me feel about myself as a clinician and make me feel about working with these people? So one of the things that I do, and we don't have a lot of time to do it in the training program, unfortunately, because it's a jam-packed schedule. There might be people here who can attest to that. But planting some seeds about having a think about yourself and your place in working with people and your reactions and responses, and not only using terms like counter-transference and things like that. We're trying to steer away from that.
Yeah.
But thinking about yourself in the room, but also outside the room as well. How might this affect, things affect you later on? When you're back home trying to juggle kids and dinner and baths and, all the rest of it, and you've had a tricky client or patient, however that trickiness actually manifests. So for a number of years now in our clinical training program, we have had this element, and we talk about empathy, and we talk about ethics too, partly because we have to as part of our accreditation requirements. But I think that we can't assume anything in terms of the people who come into our programs. We do have to make sure that we have our code of ethics as well. And that people understand that and appreciate why it's there, not just as a protection of the public, but also as a protection of yourself as well.
Yeah.
So that's a didactic part of the clinical psychology training course, and it's, I guess, clarifying people's values and their approach to practice. How about sort of developing actual skills? So I think you've talked about, to me, self-compassion and self-care. How does one actually train those in someone in a way that years down the track, when they're actually practicing out there in the wider world, it might prevent them from developing distress?
Well, one of the great aspects of our training is supervision, and hopefully developing relationships with supervisors who are often experienced clinicians, or who should be experienced clinicians, I should say, and being able to talk about these things and have an open discussion. Now, I know that doesn't always happen, that people feel, somewhat perhaps intimidated by supervisors sometimes, or uncomfortable with them, or it's just not a great mix of student supervisor. But hopefully throughout the training programs, people do at least have some opportunity to have some reflective practice, have some time to reflect, also some time to see how other people do it. Out in the field, when you're out as a trainee, being able to observe people in action and talking, well, how did you feel about that situation, and what do you do when you go home and you've had this really tough day, things like that. The other thing I just wanted to pick up, the peer group
review
stuff. Within within psychology's registration requirements, you have to have peer supervision. And we encourage our trainees to form groups that often do continue through, and they become their peer supervision groups. But it's beyond just talking about cases and did you do this and checking off checklists of CBT, whatever. It's more. It does become more about as maturity comes along in your practice, it does become more about how's this affecting you, and how's this affecting you with the next person who walks in the door. And we try and plant those seeds too, of having that level of discussion and encouraging people to form those groups early on that hopefully will carry through 20, 30 years down the track when you're working. So I think, and we do know that I've been hanging around here for a while now doing this, and might bump into people later on. And I know that people who have been trainees from when I started back early in this century are still meeting up. And I think that's wonderful. I think it's fantastic. In fact, I know that some of my colleagues who went through training programs here at Melbourne University still meet up with and that was last century, still meet up with their colleagues that they trained with. I think having that foundational bond is really important.
But it's not a requirement.
It's a requirement to do supervision, and part of that in our registration annual thing, you've got to do 30 hours of supervised supervision, and part of that is peer supervision.
But once training is over, you're on your own, unless you choose to be part of one of these groups, is that?
Well, you really can't get the hours up of the supervision without doing it, so it almost embeds it within it. Yeah.
So you've talked a bit about what happens in the clinical psychology training program, which for those who don't know is postgraduate degrees. But as is medicine now, of course, what are we doing here in medical training, early year medical training, along similar lines, if anything?
Yeah, I think there's actually some really great things that are happening in the MD. So it is the postgraduate training. It's a 3-year course. First year is pre-clinical, 2 years clinical. So one thing that already has happened is that first year of training has become just pass-fail. So students don't get a grade. And so anecdotally I've heard that there are some wonderful people who work within that program who work in wellbeing. So they're people that students can come to and have talk about things that are happening for them. Anecdotally, since they brought in that pass-fail requirement, the numbers of students in the first year who are requiring that contact appears to have decreased. Now it's early days, but that's heartening. The next step that's taking place as from next year is that first year won't contribute to a student's Z-score. So the Z-score, what I understand, is the score that all Victorian medical graduates get that helps determine their internships. So it's a ranking, more or less, based on your achievement, academic achievement over your medical training. And different universities do it differently, as far as I understand. It's not a one-size-fits-all sort of thing. Melbourne University, as of next year, that first year of training, the preclinical year, won't be contributing to people's Z-scores. So the hope is that actually reduces some of the stress, competitiveness, and so on and so forth that appears to have historically been part of that program. There are a number of other universities in Victoria who already don't count that first year in the Z-score calculation. So, people have said, well, is that going to mean that there's much more competition, drive, pressure and so forth in the other 2 years of the training? I guess we'll wait and see in some ways. Those other 2 years are the clinical years. So, it does make sense that the internship determinants are from those 2 years. So, personally, I think it's great development. The other thing that's happening, I think, from next year is the incorporation of some of the elements of the sorts of things that I think that we've brought into our clinical training program will be introduced in the first year of the MD as well. Thinking about self-care, talking about more about empathy and so forth, but in also not in a graded component of the course. So I think that's really important as well, that people don't feel that they have to, learn this off by rote, that it actually, and also talking about things like perfectionism and how that might impact on you as a professional and so forth.
Okay, I'm going to get evil for a second and ask 2 devil's advocate questions.
To me?
To you.
Oh, great.
Yeah.
Okay.
But anyone else can join in. So, and again, I'm just channeling what maybe someone in the audience might be thinking. So one thing is, okay, you've got all these wonderful things going, you 3, where you're improving the profession and how it works. And yet, this is at the very time when we're being told that the rates of depression, anxiety, distress, suicidal thoughts are at their peak. How come it's not working? Devil's advocate number 1. Devil's advocate number 2. So all of this self-care and self-compassion and taking the stress off in education sounds like it might indeed buffer people from the inevitable hardships of clinical work. But could it also have a downside? Are we perhaps coddling people? Are we preparing people who are going to be less resilient than previous generations because they haven't had to face up to quite the same stresses? Again, devil's advocate positions. How would you respond, panel?
Everyone looks at me. We're not shying away from educating our students in the realities of working with people with mental illness. I'm quite upfront. I do the self-care workshop that we provide, and I'm quite upfront and say, this is a hard, and I say this actually at the start of the training full stop, you're entering into a really hard area of employment. There's a lot. It's a stretched area to work in because of funding, and you're working with people who have often had really, really awful lives, and you'll hear terrible stories. And I'm sorry, that's part of the work that you're entering into. So I'm quite upfront in saying, you know, you're going to be confronted by some of the harsher realities of life, really, since you've chosen this pathway. So I don't think we're shying away from anything. I think what we're doing is trying to gear people up and actually being overt about it, and trying to help people start from day one developing resilience, to be able to hear these stories of the people that we're working with, to be able to work within stretched financial environments, and the sort of other environments that you've alluded to, Sid, where you know, maybe often there's unhappiness and so on and so forth. So I don't think, I personally, I'm not a huggy sort of person. I don't feel like I'm coddling anybody at all. I feel like I could have benefited from someone telling me this stuff when I, very early on in my career, had some really tough clients and tough situations that I worked with clients, and could have benefited from having someone say to me, have a think about how this is impacting on where your values lie, and have a think about where this sits with how you thought you would be working in the future. So yeah, I don't think we're coddling people.
Okay, good to know. Look, I know we want to leave some time for audience questions, because I'm very much hoping that this is stimulating some good and maybe even difficult questions for the panel. And I want to ask a few questions that maybe we can have a bit more back and fro about. So I'll just put you on the spot for your own answers. Let's say you had a magic wand, and by using it you could enact one change to current practice in the field, in any area. It could be training, could be workforce issues, could be structural. One change that would improve well-being or mental health among health practitioners the most. What might you do? Difficult question, but if you just think of one thing that might work, and you can maybe think of a second one if someone else is being a bit slow to add.
Communitarianism. That's not the same thing as communism. And it has an ethical basis, and it is a tradition of it, and it reflects on what we were talking about earlier. At every level, it seems to be, you know, high school, as you go along and things change as they inevitably must, then you do not have to do it on your own. Always to be inclusive, bring people, students, you know, different levels, retirees even, into communities where they can share and give support, where they feel safe, secure. And I'm not talking about therapy groups at all. You're talking about, I'm just talking about natural. I mean, we all live in groups, as you said. So these are not quite natural. They are groups that are founded on, if you like, some sort of natural instinctive thing. We all want to be part of something, as opposed to being an isolate.
So just to follow that up, Joe, I know you've got a thought coming, but it must be quite challenging to do this. I mean, if it was easy, people would have done it already. Correct? Or is it what's holding us back from being more communitarian? Is it structural problems? Is it that we have the wrong culture in our
No, that premise is incorrect. I'm sorry. There are communities around the world. I don't know a lot about this, but I have read some eminent ethicists, as it happens, but there are other people, you know, sociologists, and so on and so forth, who also write about these things, and they are representative communities which are there as models. Let's face it, there are other communities which are ghastly. You know, just look around the world; most of them are now in dreadful states. So I'm not saying there's something very special about health practitioners, nurses, you know, all these sorts of things. If I just I'm just make one little point. So I was at a choir rehearsal. Tonight I'm singing in a concert, by the way. Tickets are available at the door. But I was looking around and checking, I know he's a paediatrician, and I know she's a nurse. And anyway, there were 10 of us that I sort of could identify as belonging to the healthcare fraternity. And I know from previous chats with them, but I ran around quickly and said, look, I'll go up and participate in this thing. Why do you come and sing here? Because we're part of. And when I heard that phrase, I knew exactly what they're talking about. This is what, we all know. So if you belong to a singing community, it's all modeling, for other places. So I think that's
Thanks.
That's
so,
right.
Jill, with your magic wand, what would you do?
I held back because it's difficult to come up with one thing that with a magic wand would fix it all. I agree that community is important, and being able to have somebody that you can reach out to and a network is very important. But I would like to see us look at what it is within the medical workforce and the pressures both through medical student through to retirement and beyond that are becoming increasingly difficult for practitioners, and how we can perhaps respond to that, whether it's in methods of flexible work, of changing the medical workforce so that there's greater resources, which tends to mean money but does not have to mean money. It can be about the way that we work and the way that we practice. And I think one of the key components of the community aspect to it is there is sometimes a perception within the medical workforce, and it's using words that came up recently, that you have to be able to cope with a level of everyday nastiness. And I think when we have a medical workforce that assumes that there has to be a baseline level of everyday nastiness that we have to put up with, that's not the type of workplace or workforce or culture that I think most caring people would like to be within. And I don't think it's something that can sustain a caring profession. So I guess if there was one single magic wand, and it would have to be a fairly powerful magic wand, then changing the culture to be one of everyday kindness rather than everyday nastiness would be where I would try and direct my magic wand.
Terrific. But Lisa?
I'm also struggling with distilling it down to one thing that I can change with my magic wand. I mean, if I think of from a training perspective, I guess I think that sometimes we just need to. Training is really taken at a galloping pace, and I don't think that's just training of psychologists. I think training in a lot, not just in medical and health professions as well. And I'm not quite sure that that's ideal. And the galloping pace is set often by funding for courses from, Commonwealth Government or whoever. And it doesn't give people a chance to actually often think about what they're doing, strangely, and also give people the practice in thinking about what they're doing. So I think my magic wand would be, unfortunately it is probably money, because I think that giving places like universities more time to actually train students and practitioners so that they do have the practice of being able to reflect, and before you're out there in the hurly-burly of being the professional where everything's assumed that you know what you're doing and so forth.
Okay, so one last round robin here before we have the audience, and I promise I won't take very long, and we're getting towards time. Our alumni community has lots of people who are going to be in leading positions, of senior positions in their field, and or retired from it. What sort of role do you think that sort of more senior health practitioners, including retired ones, can have to improve the welfare of their more junior colleagues? Is there a concrete thing that you could suggest?
I think that we need to keep both senior and retired members involved and engaged. They have a wealth of experience, a wealth of knowledge, and often it's actually something where when practitioners retire that they also have issues with their mental health, because so much of what they have been doing over their lifetime is then gone. And I've certainly heard practitioners talk about how they feel that all that knowledge is now considered worthless and that they have nothing to contribute. But in fact, nothing could be further from the truth. There are various peer networks. There's also opportunities for example, in Victoria we have a setting where if you have a retired doctor in a nursing home, setting up people who can go and visit them allows them both to remain part of the community and contribute their knowledge as well. And I think that if we look at age as a diversity measure, we've got to consider that the people at the end of their career and lifespan have much to contribute, and keeping them engaged where they wish to do so and facilitating their engagement is a really key component of keeping that community happening across the life cycle.
Thanks, Jill. So, Lisa or Sydney, do you think that senior people can do for junior people?
Well, just a quick add-on to what Jill said. Aristotle said that life is a journey of learning, and so that alumnus who is 79 and still has lots to offer and still has lots to learn about aging, facing death. A grandchild has got autism. It doesn't stop just because it's an alumnus. So I think we should, if you like, embrace them. And the word Aristotle likes is wisdom, which I do too. They have a wisdom, which I wish all of us would have, but we can't accumulate it over the next 3 years of training in a Melbourne University course. So let's not dismiss, I don't think we do dismiss, but let's embrace the wisdom of, and I hate the word elders, of those. I don't know how to replace it. Psychiatry, we say psychiatry of the elderly. I don't know if that helps much. It used to be old age psychiatry, but anyway, you know what I mean. So embrace their wisdom,
we should develop a diploma program in wisdom.
Oh, yes. Would you lead it?
The last person. Lisa, your final
I don't think
word.
I've got anything to add. I think just echoing this, and the things that I've been talking about, they're not new things. So I think that we reflecting on talking to people who have had long careers, what sustained you through those careers? What has been able to help you to keep going, as well as talking to the people who perhaps have withdrawn from their careers, what got in the way, and so on and so forth. I think sometimes we miss out on asking the people who have been the survivors, in a way, of how they managed stuff, and I think we can learn from those survivors.